Good evening all to the 112th session of the Weekly Huddle. I'm your host Anoop, and joining me today is my friend and co-host Praneeth. We both are cardiologists working at KIMS Hospital, Secunderabad. Today we are discussing a clinical case, and the discussion I'm aiming to be as generic as possible because these are the kind of entities which pretty much we see it on a daily basis, if I may say. So this is a 54-year-old gentleman. He came for a routine clinical visit. He had an angioplasty done to his LAD and diagonal in a bifurcation fashion around 2 years back. That was done for unstable angina. He did not have troponin elevation, just some ST changes. His angioplasty was unremarkable. His echocardiogram at that time had been normal, and since then till now, he never had any problem with his LV dysfunction. He's currently asymptomatic from the cardiac standpoint. He also has a history of diabetes, which dates back about 8-9 years, and hypertension, which was diagnosed at the time of angioplasty, that is 4 years back. His main complaint this visit is episodic epigastric distress, and he points more towards the substernal region. And he says that this typically happens either when he's fasting or sometimes when he eats outside or when he eats any spicy food, particularly those street side food. He had been taking pantoprazole, sometimes on and off and sometimes regularly, that he has been doing for past 4 years now. He actually saw a gastroenterologist a few months ago, for which an upper GI endoscopy was done, and the reports of that showed mild fundal gastritis. And he was prescribed 2 weeks course of pantoprazole, which he completed. His symptom kind of went on and off, and he had been taking pantoprazole on and off since then as well. He doesn't have any other specific symptoms. He's otherwise doing his routine activity. He is a non-vegetarian, but he eats non-veg food only once or twice a month. So mostly he maintains a vegetarian diet. He still works. He works in office. He says that my work mostly is desk job, and his daily activity is limited to 15 minutes evening walk that he goes almost daily. His examination and routine labs this visit are pretty much normal. So the discussion point for today's session that we have is we are trying to manage his epigastric distress. While it is not a big problem for him, the idea here is, can we make his life a little bit better by doing some things or playing around with his medications a little bit. So I forgot to mention his medication. So he takes dual antiplatelet therapy in the form of low-dose aspirin and clopidogrel. Along with that, he takes rosuvastatin 20 milligrams. His diabetic medication includes dapagliflozin and metformin, and on that, his sugars are quite reasonably controlled. He also takes routine cardiac medications, which includes beta blocker and telmisartan. He takes lifestyle medications like vitamin D supplements, vitamin B12 supplement, some multivitamin, and that's pretty much about it. Once a while, he takes Dolo when he gets arthritis pain. So the discussion point that I'm trying to bring today is there any benefit of changing pantoprazole to some other PPI? Now, this guy has been taking pantoprazole for quite some time. He does recollect that sometimes he has been prescribed other medications, which he took the quote-unquote course, and once he completed that course, he went back to pantoprazole. So my guess is at some point he was prescribed esomeprazole or omeprazole or something like that. But for most part, he had been taking pantoprazole. So the question here is, do we have any rational belief that one PPI is preferred over another PPI for any subset of patients, or do we think that all PPIs have class effect in terms of efficacy for resolving gastritis-related symptoms? Then the second question is, a lot of times we are forced to prescribe other supplements along with PPIs in the form of antacids like Digene syrup or local anesthetic like Mecangel or a surface coating agent like a sucralfate or something like that. So uh, is there a role for these kind of drugs? How do we select which patient would benefit from this? And remember, we are not talking about peptic ulcer disease subset here. We are talking about patients with non-specific gastritis or just some GERD, gastric reflux disease. Any role of prokinetic agent in these patients? So frequently we see that these patients, they take drugs like pantoprazole with domperidone combination or etopride combination. Sometimes they take kinpride or etopride separately as well. How do we select which patient should get a prokinetic agent with reference to GI upset? And is there any role of further diagnostics, understanding that upper GI endoscopy is kind of non-significant? All it shows is some mild fungal gastritis, which could very well be the cause for his symptoms. But are there any further diagnostics that we can do to help this patient resolve his symptoms? So very generic complaint, something that we see on a daily basis. And from the mortality or hard clinical endpoint, maybe these are not relevant, but from lifestyle or morbidity standpoint, they definitely deserve attention. So Praneeth, I'll take your comment. How do you manage these cases? And then I will ask a few of my attendees. And lastly, we'll take opinion from our expert for today's discussion, Dr. Raghuram. He's a gastroenterologist, and he will help us dissect some of these points out. So Praneeth, over to you.
Yeah, good evening, everyone. So, firstly, this patient who is a known case of coronary artery disease who underwent intervention, whenever he complains of epigastric discomfort, first thing I want to be doubly sure is that it is not a cardiac issue, because we know that close to 30% of patients who have a cardiac issue can present as an gastric issue like this non-specific gastric pain or like the acidity pain. So his consistency of pain with intake of food and not having any exertional symptoms, to a certain extent, is not suggestive of a cardiac issue, but I would still be suspicious. But for the sake of discussion, I believe because his physical activity does not promote any of these symptoms and its consistency with relation to food, I would consider this to be a non-cardiac issue. Now he has gastritis for which he is taking on and off pantoprazole. If that is making him comfortable, I would try to, or I would suggest him to take it as an unrequired basis to abate the symptoms. He is 2 years old, his PCI, and he's on aspirin as well. So if aspirin is the cause for his gastritis, which could be a possibility, I would cut down aspirin for him, continue single antiplatelet and other drugs, and try to see for the response. Also suggest him to do some lifestyle modification in terms of having some regular food habits and trying to cut down some of the spice or deep fried items, which probably can contribute to his acidity. Stress also, to a certain extent, can contribute to gastritis. If there is anything, I would also suggest him to kind of manage his stress in the form of doing some exercise or follow some meditation. For the usage of drugs for any change of PPI from pantoprazole to any of them, in my opinion, more or less everything works the same. It is a class effect. So I do not expect much of a change when pantoprazole is being replaced by other PPI. Maybe it works more as a placebo than as any significant effect. In my opinion, they are all belong to the same class, and one may not score better. This is something which I would like to learn from today's discussion. Addition of other agents, like if the patient has predominantly acidity or these symptoms after intake of food, and if that is something which is contributing, probably taking an antacid might help in neutralizing that acid and helping relieve the symptoms. Because it does not have any ulcer, I don't think sucralfate will have any role here. Maybe these antacids like that magnesium, aluminum hydroxide things, plus or minus addition of an local anesthetic might be of help for him in abating the symptom after intake of food. A role of additional investigations, I don't know, but if the patient is having symptoms consistently, I would refer back to the gastroenterologist to have a relook whether something that I'm missing or any special investigation which he seem appropriate can suggest. In my opinion, I don't think doing any other investigation will probably add value other than doing an endoscopy which he already underwent. So on and all, a bit of a reassurance and some change of lifestyle modification, cutting down aspirin should be the deal for me.
Thank you, Praneeth, for this. One of my question to you is, what are the red flags in this kind of patient subset where you start saying, let us refer back to gastroenterologist, understanding that they already had one visit or a few visits before?
If the discussion predominantly revolves around this only symptom, where if he is significantly bothered and if it is bothering for most of the days in a week, and despite making some changes, like despite stopping aspirin and he doing some lifestyle changes, if this continues to bother him and it becomes his predominant symptom, then I would be worried. And if any other symptoms in terms of melena, weight loss, loss of appetite, if any of these symptoms occur, some vomiting, then I would be worried. So other than that, I would probably take it easy.
Okay, thank you, Praneeth. Thank you so much. I will continue my discussion. I will ask Shankar sir to give his opinion. Shankar sir, I'm sure you are bombarded by patients like these, may not be having a cardiac component, but definitely upper GI symptom is one of the most common symptomatology which brings patient to a primary physician. Understanding that this patient, while he has a cardiac problem, the current presentation is highly unlikely to be cardiac. How do you handle these kind of situations in terms of therapy management and referrals? Shankar sir.
Good evening to all. Such type of symptoms and presentation commonly we encounter in our clinical practice. So I fully agree with Dr. Praneeth Polamuri, what he has mentioned, because there is a fungal gastritis, already patient on aspirin. So already 2 years over post PCI. So we can switch on to only single antiplatelet, that is a clopidogrel, and we can stop aspirin. But the esophagus appears to be normal here, but the esophagus can be normal even in GERD. The gastroesophageal reflux disease is one of the mimickers of cardiac chest pain. So it is the commonest cause for the non-cardiac chest pain, NCCP. So GERD can present with the normal endoscopic esophagus. So here we give, after stopping the aspirin, give a trial of antacids if it is mild enough, but here the fungal gastritis is there. I prefer to give PPIs, proton pump inhibitors, omeprazole, lansoprazole, esomeprazole, rabeprazole, pantoprazole, so many are there. But the pantoprazole is amongst them, it is a little weaker. Most of the times, what we in the cardiology practice, when the patient is on clopidogrel, most of the times we avoid esomeprazole, omeprazole or esomeprazole. We prefer to give pantoprazole. Here, we can give this 4 to 8 week trial of PPI. if we respond, then it is crystal clear that we are dealing with acid peptic disease. Then the GERD patients, they present with heartburn, chest discomfort also, and a reflux of this regurgitation, reflux of the food contents into the esophagus or into the oral cavity. They may be present with nausea. So here, sometimes this GERD may be complicated by erosive esophagitis, ulcers, then strictures, Barrett's esophagus. Then sometimes we see in our clinical practice, if the patient not responding to medications, complaining of cough, so we think of even GERD also one of the causes for this irritating cough. And the asthma, bronchial asthma also can be provoked by this GERD. Sometimes the patients may present with hoarseness of voice, and sometimes they may present with a sore throat. So the uncomplicated symptoms are heartburn, chest discomfort, reflux of food contents, and nausea. But where they are complicated, they may present with ulcers, strictures, Barrett's esophagus, diagnosed by only endoscopy, and they may present with the cough and asthma and hoarseness of voice and sore throat. So then we give a therapeutic trial, as I mentioned, proton pump inhibitors for 4 to 8 weeks once daily for 48 weeks. If they don't respond, and then we subject them for we refer them to gastroenterologist for endoscopy to see any erosive esophagitis. That may be graded with the Los Angeles classification ABCD. Then further investigations like the 24-hour esophageal pH monitoring. The pH metry will be done so that we can find out any GERD there or not. The reflux of acid into the esophagus there or not will be found out by this esophageal monitoring or impedance, pH impedance. Then recently, then capsule has come from Medtronic company, also that diagnosis. So ambulatory pH monitoring is possible to find out whether the GERD or not. And sometimes we may resort to esophageal motility studies, so that the eclasia cardia like conditions they may not be missed. So having sent for endoscopy for esophageal monitoring, the esophageal motility studies, we diagnose that it is whether it is a GERD is confirmed or not. We can find it out other than symptoms. Then we give this proton pump. If it is mild enough, we give only antacids and H2 receptor blockers like ranitidine and famotidine. But here the fungal gastritis is there. So preferably I give proton pump inhibitors for 48 week trial. If it doesn't respond, then twice daily these proton pump inhibitors can be given up to 3 months. If it doesn't respond, I refer to gastroenterologist for further evaluation. The alarming symptoms alluded to by Dr. Praneeth, like the patient has got a dysphagia, a hematemesis, a weight loss, an anemia. So in those situations, we have to, in those situations of alarming symptoms, we have to refer it to gastroenterologist for the further evaluation. So up to my, this thing is, If the mild symptoms are there, we give antacids like and H2 receptor blockers like ranitidine or famotidine. But case like this, moderate to severe symptoms, then we give PPAs once daily for 48 weeks. Then later we give twice daily for even up to 3 months. Then the prochitinic agents, they increase the LES, the lower esophageal sphincter pressure. So, and also empties the gastric contents or down. So sometimes we give prokinetic agents, also promotility agents like etopride and syntopride, cisapride and all, they can be given. So the latest, the foam barriers, the Instaraft and the Raciraft has come into the market. They give instantaneous relief by forming foam with the alginic acid, alginate. So that also we give in the symptomatic therapy in these patients. And further clarification and enlightenment, I look forward to Dr. Raghuram, gastroenterologist specialist. So thank you, one and all.
Thank you, Shankar sir. Praneeth, I'm going to come back to you. I have a question for you. First of all, as a cardiologist, we need to sort this thing out. This guy is on aspirin and clopidogrel. It's been 2 years post stenting. He had 2 stents placed, LAD and diagonal, in a bifurcation fashion. While he's doing okay, how comfortable you are backing off on single antiplatelet, or would you like to continue dual antiplatelet for lifetime?
So younger patient, if he does not have any significant bleeding risk, I would be tempted to actually continue dual antiplatelet therapy. But having said that, these symptoms are bothering him. So I would consider for a short period to see whether aspirin itself is the culprit for his gastritis. So if his symptoms are getting better, probably I would be okay. Versus if his symptoms are not, I would be comfortable actually continuing dual antiplatelet therapy.
So again, the question here is, we kind of find something which is most obvious, but we also have to understand which one is more likely. So this patient who got an angioplasty done 2 years back, but his gastric symptoms dates back to 4 years, 5 years, maybe even longer. So technically aspirin came into his life only 2 years ago. I understand the apprehension of continuing something, but are we overreacting for the lack of no benefit? And secondly, what is our strategy? If we do stop aspirin, let's say, is there a plan that if in 2 months symptoms do not get better, then we restart aspirin? Can there be a plan, something like this?
So again, it doesn't make any significant sense, but we can consider actually that first thing is you continue dual antiplatelet therapy and give pantoprazole. But if after taking pantoprazole it still continues, then you probably stop aspirin, continue pantoprazole, and if it gets better, if still doesn't work, then now that he's okay on a single antiplatelet therapy, restarting a second antiplatelet therapy doesn't practically make any sense. So after stopping, restarting I would not consider. So before stopping itself, I would be very careful and have a very high threshold to stop second antiplatelet. But once stopped, unless there is again another indication for me to restart, I would not consider restarting the second antiplatelet.
All right, thank you. I will move on, and the floor is open for discussion. If anybody has got any questions or comments, they can unmute themselves or raise their hand, and they can speak out their questions. And while you are doing so, I will ask my attendees. In fact, I'm directly going to go to Dr. Raghuram for his opinion. And I think that we have a little bit of background set in terms of how we want to approach this patient who is already on pantoprazole, the idea of stopping aspirin, the idea of giving him twice daily dosing, idea of asking him to take it on a daily basis, at least for a short period of time. Lifestyle measures, Praneeth mentioned, which has already been discussed multiple times with this patient. I guess the onus of pushing for more and more lifestyle changes at some point becomes impractical, because now the patients, their lifestyle defines who they are. So unless it is a life-threatening issue, or unless it's a major medical issue, uh, at some point it may become it becomes unfair to ask them to change their lifestyle dramatically for these kind of symptoms. So, Dr. Raghuram, I'm going to ask you a few particular questions, but before that, I want to hear your comments about this patient. If this patient were to be referred to you, who already had an endoscopy done before, to whom doctor says that, okay, whom cardiologist says that, okay, we can stop aspirin, but let us see what your gastroenterologist recommends. My question to you is, how would you take up his medical therapy? Would you do any diagnostics at this point? If you could please share your thoughts about the pH manometry, pH metry or esophageal manometry that Shankar sir told you about. And then I have few dedicated questions for you also, but if you could please share your thoughts about these things. Dr. Raghuram.
Yeah, thank you, Dr. Anoop. So, Dr. Praneeth and Dr. Shankar have made my job quite easy. So, you may be having some background noise. Give me a minute or so. Whenever I encounter these kind of patients, I try to arrive at a syndromic diagnosis. Two possibilities. One, whether the patient has dominant GERD symptoms or acid reflux symptoms. When we try to fit him into a GERD syndromic diagnosis, and the other broader group would be a person who has abdominal discomfort and predominantly symptoms related to the dyspepsia. We don't use the term acid peptic disorders anymore. So we would try to fit the patient into one of these syndromes. So in this patient, he has an epigastric discomfort which fits more into a dyspepsia syndrome. So obviously, the protocol would be to go ahead, do an endoscopy. The basic idea is to look for a H. pylori infection, right? So once we diagnose the H. pylori infection, we try to eradicate the infection completely. And usually we prescribe an antibiotic course of 14 days. The 10 days treatment is obsolete now. So uniformly, it is a recommendation of 14 days treatment. And of late, what is becoming more important is the antibiotic resistance among the H. pylori strains which are seen in India. Lastly, we had a study from Karnataka in 2020 which showed significant resistance to both amoxicillin and clarithromycin. So usually the guidelines mention that we need to take the local resistance patterns into consideration and decide on the antibiotic regimen accordingly. But we usually tend to go ahead with the amoxicillin and clarithromycin based regimen for 14 days. And we check for eradication of the H. pylori after 3 months via either a urea breath test or a stool antigen test for H. pylori. Now, that would be the aspect about dyspepsia syndrome. Then the other broader aspect, acid reflux or GERD. So here, the treatment with PPI would be for very long periods, because whenever we talk about GERD, there are two underlying causes. One is anatomical abnormalities with the lower esophageal sphincter, be it in the form of a patulous G junction or a hiatal hernia. So both these things, they don't have a proper medical management, and with medical management, the relief tends to be very transient. So definitive treatment, we obviously plan for a surgical aspect whenever we are dealing with some structural abnormalities like a very patulous G junction or a hiatal hernia. The other significant factor which is associated with acid reflux is obesity or BMI being on the higher side. So GERD is directly proportional to the elevation in the BMI. So if that is the case, we mention the importance of that aspect to the patient and encourage him to reach a normal BMI. And that may look as a endpoint when we are talking about stopping treatment in GERD. But in structural abnormalities, we may have to continue the PPI for longer periods and lifelong in most scenarios. But in dyspepsia syndromes, once we eradicate H. pylori regimen, there is no role for prolonged PPI therapy unless and until the patient is on other agents which can lead to gastritis. So the drug the drug that we are talking about relevant to this scenario would be the aspirin thing. So yeah, if we have the liberty of stopping ecosprin, I would suggest that we stop ecosprin and just continue with clopidogrel alone if the situation permits, because that would tend to perpetuate the gastritis and force us to give PPI for longer periods. So that's one aspect to it. But say if the person is not on aspirin and his H. pylori infection has been eradicated, and we have reason to believe that the gastritis component has settled, then we arrive at a diagnosis of a functional dyspepsia. And in such situations, more than continuing PPI for longer periods, we tend to put them on tricyclic antidepressants. Amitriptyline is the agent of choice, and there's good amount of evidence to suggest that amitriptyline works very well in case of functional dyspepsia. So that those are my viewpoints on the thing. Coming to the role of the 24-hour pH metry. Now, GERD is basically a syndromic diagnosis. We don't need an endoscopy to confirm the diagnosis of GERD. And like Shankar sir said, there is a component of non-erosive reflux disease, which can be seen in almost 30 to 40% of people who have a syndromic diagnosis of GERD, right? And the remaining 40 to 50% would be the erosive GERD, which is very easy to diagnose. And we can aim for symptomatic relief and try to correlate with the endoscopic findings. So in cases of non-erosive reflux disease or where the patient is not responding to standard PPI, now there is little to choose one agent over the other. When we are talking about the PPIs, it's basically the duration of action. So the more potent agents like rabiprazole and esomeprazole have a slightly prolonged duration of action. But having said that, pantoprazole has a duration of action of around 12 to 14 years, which is 12 to 14 hours, which is good enough for providing symptomatic relief. So that is the thing. And yeah, obviously clopidogrel PPI interactions. So if a person is on clopidogrel, we try to avoid omeprazole and esomeprazole. Although we have trials like the Cogent trial, which showed that even in patients who were on clopidogrel along with omeprazole, the cardiac composite endpoints were similar. So although on paper we see that there is an interaction between omeprazole and clopidogrel, the efficacy wise, it didn't show much difference whether we are using omeprazole or the other PPIs. So that is one thing. Yeah. Over to you, Dr. Anoop. Any new questions, further queries? I would be pleased to answer.
Role of prokinetics in dyspeptic symptoms and these supplements, like, these we give this Digene supplement or this Mucan gel supplement, all these things. Like,
Yeah.
is it for all comer is it for all comer dyspeptic patients or only selective who had documented ulcer before?
So in patients with dyspepsia or GERD, the guidelines mention that the usage of prokinetics, be it domperidone or cinetapride and the other agents that we are talking about, the role of prokinetics comes when there is a component of gastroparesis. And in cases where there is no component of gastroparesis, so there is little role for prokinetics. Now, the caveat here is it's difficult to diagnose gastroparesis because obviously we have to go for a gastric emptying study, that to liquid and solid both. So in the absence of those studies, and if there is reason to believe that gastroparesis may be at play and causing symptoms, like the person has diabetes or hypothyroidism or CKD, and all these things, they are known to reduce the intestinal motility in general and cause gastroparesis as well in specific. So in such situations, even in the absence of a proper gastric emptying study, we may be deciding on giving prokinetics. But otherwise, in the absence of gastroparesis, there's little role for prokinetics as such, be it GERD or the dyspeptic syndromes. Then the role of antacid syrups in patients who have refractory GERD, the usual approach is to, tweak the dosage of PPI. Instead of giving single daily dosage, we try to give a twice daily dosage. And that works quite well in case of refractory GERD. And in case we don't see a response to the twice dosage of PPI, then we tend to add sodium alginate. So sodium alginate preparations are, we have Gaviscon, and like Dr. Shankar said, we have preparations, other preparations like Instaraft, Digiraft, which are sodium alginate preparations. Basically, they tend to form a layer over the stomach contents. And whenever there is a reflux of these contents into the esophagus, it's predominantly the raft which comes in contact with the esophageal mucosa and prevents the acid-related damage of the esophagus. So that's the role of antacids. The other agents like sucralfate or Digene and the magnesium aluminum hydroxide preparations, they give more of a symptomatic relief to the patient. But when we talk on the evidence aspect, there's little to recommend these agents. Sucralfate, again, we need to understand that sucralfate forms polymers at a low pH. So if we prescribe sucralfate along with a PPI, the pH tends to rise, and the sucralfate doesn't get a chance to polymerize. And the purported benefit of sucralfate by coating the ulcer base, that takes a hit. Now, of late, they have come up with studies which say that even the monomeric sucralfate is helpful in um, having an ulcer protective effect, but we really don't know how far that's effective. So if we tend to give sucralfate in combination with PPI, essentially we are nullifying the effect of sucralfate. So that would be the role of prokinetics and the antacid syrups.
So, Raghu sir, questions for you. Number one.
Yeah.
Is gastritis or dyspepsia and peptic ulcer disease, is it in the single continuum? Are we mixing two diseases together? Is peptic ulcer a standalone symptom of H. pylori infection or an exclusive symptom of H. pylori infection? My question to you is it a continuum of the same disease, or these are two different diseases that we're talking about?
Excellent question, Dr. Anoop. So, like you already have an inkling, this is a continuum of the same disease. On one end of the spectrum, we have mild gastritis. Now, severity-wise, we look at the presence of erythema, be it in fundus, body, or antrum, and presence of edema, mosaic pattern. And as these new things add up on the endoscopy thing, we realize that the severity of gastritis is increasing. And on the other end of the spectrum is the peptic ulcer disease. So basically, it's the same disease. And we have on one end, we have the mild gastritis. On the other end, we have the peptic ulcer disease. And 90-95% of the times, it is H. pylori. Only in the remaining 5 to 10%, we have other agents like the NSAIDs, aspirin, which are causing the gastritis.
So again, the question again comes back to that same thing that I'm dragging you into. When you do an endoscopy, do you do H. pylori test on all comers, only the one with ulcer, or the one with ulcer and gastritis? How do you select?
So I do the H. pylori test in all cases. The only cohort where I try to avoid the RUT is when the endoscopy, the stomach and duodenum are totally normal. And if they don't have even a patch of erythema, and when we say a totally normal stomach mucosa, there is a classical pit pattern on endoscopy. So if that is the case, there's no point looking for H. pylori or trying to treat the H. pylori, even if it exists there. But in other situations, even in mild cases of gastritis, I do take a H. pylori thing and we try to eradicate that. Now, this assumes significance because earlier even we were under the impression that in a country like India, where H. pylori is considered as a indicator of the general health situation or the sanitation status of a country. So if we look at population prevalence studies, even in asymptomatic people, the prevalence of H. pylori in India is to the tune of 30 to 40% when we look at the aggregate of all kinds of studies. And mind you, this is asymptomatic general population, not people who have dyspeptic symptoms. So we are not trying to diagnose all these 30-40% people who have H. pylori in their stomach, and we don't try to eradicate the infection in all of them. So like over the past 2 years, we have seen that COVID has problematic strains like the Delta and mild strains like Omicron. So in H. pylori as well, the same concept holds good. There are problematic strains like CAG-A and VAC-A, which tend to cause more severe disease, more severe gastritis, ulcer disease. And on the other end, there are mild strains which don't cause any kind of stomach involvement. So on endoscopy, if the stomach is totally normal, the pit pattern is totally normal, then I won't take a biopsy to confirm the H. pylori. And in other cases, even if it is a mild involvement, we do take a sample for H. pylori and try to eradicate the disease.
Okay, so last question on this particular topic, and then I'll switch. If you say that dyspepsia and most of the like 99 or 95% that you quoted of the time it is H. pylori, a lot of these patients who have dyspeptic symptom but no red flag, can we
Yeah.
advocate empirically treat for H. pylori, or you think that's an over treatment?
That's an excellent question. So taking into consideration this commonly encountered scenario, the guidelines say that we need to categorize patients based on the presence or absence of alarm features and the age of the patient. Say the person is less than 40 years and of late they are reducing the age to 35 years. A person who is less than 35 years of age in the absence of alarm features, there's a concept called as test and treat strategy. So when we say test and treat strategy, you go for non-invasive measures like urea breath test or a stool antigen test for H. pylori, right? And if that comes as positive, you give the patient an anti-H. pylori regimen. But say the patient is more than 35-40 years of age, and in the presence of any kind of alarm features, you need to do a endoscopy, because you don't want to miss out on a neoplastic process or any other mimicker, right? So that's the way we proceed in such situations. So empirical treatment, no. There are ways, non-invasive ways of looking for H. pylori, which is a urea breath test or a stool antigen test for H. pylori, which is available in all kinds of labs. We need to be sure that the patient is off PPI for at least 7 to 10 days before we go for these tests. And if the test comes as positive, we treat them with anti-H. pylori regimen.
Okay, so the question that comes for rapid urease test or RUT are two. Number one, how commonly it is available, and secondly, how reliable it is when you compare it with a direct H. pylori assessment used using endoscopy.
So the rapid urease test is done by taking a sample of the antrum while doing endoscopy, and this is a card-based test. So has got good amount of sensitivity and specificity. The other non-invasive measures that I was talking about is urea breath test and the stool antigen test, which are self-explanatory. Yeah, so when we do a rapid urease test, this is not a standard protocol. And when we think about diagnosing the H. pylori thing, there's a Sydney protocol that we follow. So on endoscopy, we take at least 5 biopsy samples, one along the one from the body along the lesser and greater curvature, one from the incisura, and 2 from the antrum again along the greater and lesser curvature. So altogether 5 samples, and we send that for histopathological analysis. So that is the Sydney protocol, which is recommended for confirming H. pylori. But in routine practice, we tend to use the rapid urease test because it gives a spot answer about the H. pylori infection. And yes, the sensitivity and specificity are very good with the rapid urease test as well.
And how about the urea breath test that you are mentioning? How good are they?
Yeah, urea breath test and stool antigen H. pylori, these are also having sensitivity about 90-95% in most of the cases. But the usual thing that we tend to see is the urea breath test. In my clinical practice, at least I see that first and foremost, the sensitivity, highest sensitivity is with the endoscopic thing, where you take a direct biopsy or rapid urease test. Second in line would come the urea breath test, and the least sensitive is the stool antigen test. But mind you, this is my experience. On paper, it's quoted that all 3 are equally good.
And then last question from my side, and then I'll take questions from the chat box. Is there ever a situation where you prescribe H2 blockers and PPI both?
So in situation where we understand that it is a functional dyspepsia, where the abdominal symptoms are playing a dominant role, before weaning the patients from PPI, we use the H2 receptor antagonist for a temporary, as a intermediate milestone. So if a person is on double dose PPI, we switch over to PPI in the morning and the H2RA at night. And slowly we ask them to stop the H2RA. Then they'll be on once daily PPI. Then we switch over to an alternate day regimen. Say the person takes the PPI today, we ask them to skip tomorrow's dose and take it day after tomorrow. And the other thing that we need to understand is the H2RA have, their tolerance rates is very high. So after usage of 5 to 7 days, the efficacy and the drug is not effective anymore. So we can use it for very transient periods, and after that we may have to give a break and restart things. So not as a sole agent, but when we realize that the endoscopic findings are of less severity, whereas the symptom complex is on the higher side, more of a functional component. And in such situations, we use the H2RA.
Dr. Raghu, I'm just reading few of the questions which have been popped up on the chat box, and I will ask you to address those. Pranit asks, does increasing the dose of pantoprazole from 40 to 80 makes any difference?
Now, in cases of peptic ulcer disease, till the ulcer heals, we tend to use a double dose PPI. So that is one scenario. In H. pylori regimen, it's usually a double dose PPI. Whatever HP kits are available, they contain double dose PPI. In cases of refractory GERD, instead of doubling the dose of PPI, what has been recommended is to use a twice daily strategy with half the dosage. Say if you are using 40 mg PPI, you can halve the dosage to 20 mg in the morning and 20 mg in the evening, right? So double dose PPI, definitely in case of peptic ulcer disease, till we achieve the healing of the ulcer. And in H. pylori regimen, it's double dose PPI. In GERD, refractory GERD, so most of the times what has been noticed is the GERD symptoms, they tend to be refractory because of improper usage of PPI. Ideally, it's said that the PPI needs to be taken at least 30 to 60 minutes before a meal. So some people, the time interval between PPI and the meal tends to be very less, and that may give a appearance that the GERD is refractory to PPI. But once we look at these finer aspects, we can just continue with a single dose PPI or half dose PPI used in a twice daily regimen.
But there is no situation where you will use 80 milligrams twice daily, right?
80 milligrams twice daily, never. We don't use that dosage. When a person presents with acute GI bleed, we tend to give the PPI infusion. So that's a different scenario. The PPI infusion is given for at least 72 hours. So there we tend to give 8 milligram per hour infusion for at least 48 to 72 hours.
Okay, Dr. Pratyusha, if you have something to add or comment, you can please raise your hand. I'll give you a chance to speak. I'll continue the questions which are there in chat box. Dr. Raghuram, one of the question is this metformin causing heartburn. Now I know that there has been a lot of discussion about metformin, about the GI side effects, but to my understanding, they are mostly subjective. There is no objective evidence of metformin causing any damage to the GI tract. How often do you see metformin being the culprit of an organic disease, or stopping metformin actually makes things better?
With metformin, the usual problem that we encounter is diarrhea. Now, there's no typical pattern to this diarrhea with metformin. People may be using the agent for years altogether, and suddenly they develop diarrhea out of the blue. And again, metformin may be the culprit agent. And some people may experience metformin related diarrhea in the very beginning, and as time passes, they tend to get over this side effect. But talking about dyspepsia related symptoms or GERD related symptoms with metformin, metformin, we tend to see a nausea kind of effect. But other than that, at least I didn't encounter this side effect with metformin.
Perfect. Thank you. Another question which Rahul asks, quite relevant, is this whole thing about B12 deficiency, PPI
Yeah.
and B12 deficiency. Again, is it a made up story? Is it a true story?
Now, yeah, there were times when we were assuming that vitamin D deficiency is almost universally there. Over and above that, B12 deficiency is also assuming the same position these days. Now, the very reason why we are seeing B12 deficiency very commonly these days is the sole source of B12 in whatever food that we consume is by bacterial contamination. So when we say non-vegetarian diet has good amount of B12, it's not that the chicken or the red meat has B12 inherent with the meal that we consume, but it's basically because of the secondary bacterial contamination of the meat, right? So what's happening is over the past 2 years, because of the COVID pandemic, our hygiene measures have been at an all-time high, and we have been washing our hands repeatedly. We have been using sanitizers of all kinds. So the possibility of bacteria or bacterial contamination of food items is at an all-time low. And whatever B12 deficiency is secondary to this less B12 entering our digestive system, because the food doesn't have B12 at all, right? So that is the basic reason for B12 deficiency, which has become very rampant these days. Over and above that, yeah, long-term usage of PPI, we haven't talked about the side effect profile. So there are many concerns. Just to highlight a few, there is mention of dementia, interstitial nephritis, long-term usage leading to calcium deficiency, magnesium deficiency, adversely affecting the bone health, osteoporosis. Then there is a mention of Clostridium difficile, diarrhea secondary to chronic PPI usage, high rates of pneumonia secondary to chronic PPI usage, B12 deficiency, iron deficiency. So the list is a never-ending one, I would say. So yeah, the only situation where the chronic PPI is required, in my opinion, is a person who has GERD and who are not keen about reducing their BMI, who are not keen about diet and lifestyle measures, and people who have structural abnormality like a hiatus hernia or a pateless GE junction. So only these people would require PPI for very long periods or years altogether. And the dyspeptic patients, we have an answer for them. So eradicate H. pylori, and once you are sure that you have eradicated H. pylori, they would fall into a functional dyspepsia category, and we need to treat them with PPI sparing agents like the amitriptyline and the basically desensitizing agents. Mm. So that would be the way forward.
Thank you, Dr. Raghu. In sake of time, I'll see if there are any relevant questions that I will pick up. So Can we time prokinetic drug with equaspirin in diabetic gastroparesis? I think that is very optimistic. What should be the treatment for H. pylori? How many days? I think you brought it up. It is amoxicillin, clarithromycin for 14 days for H. pylori. How long it should be given, or just a stat dose? No, it's a 14-day. How reliable is RUT? That we have answered. Having a female patient, when can we suspect autoimmune gastritis? What is autoimmune gastritis, Dr. Raghu?
So autoimmune gastritis is a very, very rare phenomenon. At least in my 10-year tenure, I have seen only 2 cases till date. So yeah, the common variant, obviously, if we say we talk about autoimmune gastritis, pernicious anemia is a form of autoimmune gastritis, right? But the autoimmune gastritis that I am speaking about, which is very, very rare, is akin to the other autoimmune disorders where the immune system is attacking the stomach. And in such situations, we have to rely on immune suppressing agents. Again, the common agents used in such scenarios would be steroids or azathioprine, because azathioprine has got a more immunomodulating action, and the side effect profile is not so alarming as compared to steroids.
Thank you, Dr. Raghu. I think that in the chat box, those were the questions that I had. It is 8:05. I will now ask Somaraju sir for his opinion about today's discussion. And if anybody has got any other comments or questions, please feel free to put it in the chat box. Somaraju sir, your opinion about today's discussion.
Thank you, Anoop. It's a common problem, but not seriously addressed. And I'm glad that you are bringing it up. Only 2 issues I'll point out. Can you tell me the number of drugs this patient is receiving?
Sir, I'm just counting. Maybe seven tablets, I'm guessing.
Yeah, maybe more. Sometimes they don't tell you. Then polypharmacy is often the cause of many of these problems. Whenever anyone takes more than 4 or 5 drugs, the interactions between them, the effect of what happens to them is unknown. And that's first issue to be addressed to. Second issue I want to also bring out is on metformin. Metformin produces all variety of gastrointestinal side effects. That includes diarrhea, that includes constipation, that includes intermittent diarrhea, that includes upper GI symptoms, significant. In my own personal experience, I'm not that young. I've seen a significant number of patients where stopping metformin made a dramatic difference in significant number of patients. The first thing you have to do in this patient is change over metformin from metformin to something else. Do other things only later. That's the only thing I wanted to point out.
Thank you so much, sir. If there are no more questions or comments, I will ask Praneeth to give his closing comments about today's discussion.
Yeah, Anoop, a fairly common situation that we encounter, usage of proton pump inhibitors is quite common. Every specialty uses them, and most of the times once we start, there is no end to it. We tend to forget why we started it, and irrespective of whether patient has symptoms or not, these drugs are continued. At the same time, when patient really has an indication, how do we give them and how do we titrate them is something which is relevant, and many valid points have been brought up. The discussion of the GERD, reflex esophagitis, H. pylori infection, and in those situations, the pantoprazole will be the most important drug in their prescription to abate the symptoms. At the same time, looking for other causes. The point of lifestyle modification where reducing the BMI in relation to GERD was absolutely fine, though will be difficult in majority of them, but I think we should emphasize that. And Dr. Somaraju sir's comment on metformin being linked to many of the GI side effects, we have read and we experience it. It just does because it is a common drug and a first line drug for management of diabetes. But considering it to be stopped when GI symptoms are bothering is also probably something that we should consider now that there are new drugs available for better management of diabetes. And overall, keeping gastroenterologist into consideration and taking his opinion into what is the possible cause for the GI distress and any further modifications is always worthwhile. So taking in gastroenterologist at least once is probably relevant in a patient who complains of this GI symptoms. This is the carry home message from my end.
Thank you, Praneeth. Thank you, all of you, for attending today's session. Special thanks to Dr. Raghuram for sparing his time with us. As you all know, we do huddle discussion every Wednesday at 7 p.m. And a lot of these sessions are recorded and uploaded on YouTube and Castbox. So if you want to hear any of the old sessions, you can use your dead time for that. We will meet you again next Wednesday with a new topic. Till that time, goodbye and good night for today.
Good night.